Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of speaking to two of the authors of a very important study that was recently published in our journal titled Circulating Tumor DNA in the Diagnosis of Ovarian Cancer, a Systematic Review. First is Cristina Taliento, who is at the University of Ferrara, Department of Medical Sciences in Ferrara, Italy, and KU Leuven, Department of Development and Regeneration in Leuven, Belgium, and also currently in Heidelberg, Germany, with Professor Stefanovic doing additional extended research. And we're really looking forward to speaking with Cristina Taliento and also with Giuseppe Vizzielli, who's professor, University of Udine, Department of Medicine, Udine, Italy. Really pleasure speaking with both of you, and thank you for accepting our invitation to speak on this very important and of course, obviously relevant topic today.
Thank you, Pedro.
So, thank you very much for having me. I'm very happy to be here with you to talk about ctDNA in ovarian cancer.
Fantastic. Well, thank you both once again. Cristina, I'll start with you. Let's start by discussing what is ctDNA for those not as familiar, and how has it been used in other cancers so far?
So thank you for the question. And so circulating tumor DNA, or ctDNA, is fragmented double-stranded DNA shed by the tumor cells into the bloodstream as a result of apoptosis, necrosis, and also active secretion. So it can act as a kind of molecular fingerprint of the tumor. And there are many different ways to differentiate this tumor DNA from all the normal circulating DNA that floats around in the blood. One common way is looking for copy number changes or genomic rearrangements. Another way is looking at epigenetic changes such as methylation of some genes, or you can look at single nucleotide variants. And regarding a clinical application for many solid tumors, ctDNA is a well-established prognostic marker. It has been shown that ctDNA significantly correlates with progression-free survival and overall survival. And also in ovarian cancer, we have pooled data that show that ctDNA has a role as a prognostic marker. However, when we look at whether ctDNA can actually guide treatment decisions, the evidence is still limited to just a few cancer types, mainly those with the highest incidence and mortality, like lung, breast, and colorectal cancer. For these tumor types, randomized clinical trials have been conducted to test whether ctDNA-guided treatment strategies like escalating therapy, switching regimens, and adding drugs lead to a survival benefit. And also, ctDNA can also be used not just for prognosis, but for early diagnosis and screening. A big milestone came in 2024 when the FDA approved a ctDNA-based screening test for colorectal cancer in average-risk individuals. And when we move to ovarian cancer, one encouraging point is that ovarian cancer is considered a shedding tumor, meaning that it tends to release a relatively high amount of ctDNA compared to other tumors. But there are still several biological and technical factors that can interfere with detection. And we are still trying to fully understand and address how to address those challenges.
Excellent. Thank you, Cristina, so much for that very clear introduction to this topic. I'll turn over to Giuseppe now. And two terms that oftentimes we hear, perhaps interchangeably. What is the difference between cell-free DNA and circulating tumor DNA? And how does circulating tumor DNA differ from traditional biomarkers like CA125 in terms of biology and reliability?
Thank you, Pedro, for the nice question. So cell-free DNA or cfDNA is the total pool of extracellular DNA fragments circulating in the bloodstream. Most of the circulating DNA in plasma originates from the hematopoietic system, with the neutrophils and the lymphocytes being the main contributors. Unlike DNA from non-cancerous cells, circulating tumor DNA carries the same genetic alterations as the tumor, such as mutations, copy number changes, or methylation patterns. Although CA-125 is produced on the surface of the Mullerian origin cells, it's also produced by mesothelial cells, peritoneum, pleura, etc. And false positive almost always results from benign gynecologic condition like endometriosis or pelvic inflammatory disease. One study included in our review confirmed that the ctDNA methylation test did not detect the same false positives because these are caused by different reasons. There are two different biomarkers. Some studies included in our review compare CA-125 and the ctDNA, and in most cases, the sensitivity and the specificity were higher for ctDNA compared to CA-125. However, we already knew that the use of CA-125 in diagnosis is limited. So we know that both in the PSCO trials and the UK CTO-CS trial showed that CA-125 screening, even when combined with transvaginal ultrasound, did not reduce ovarian cancer mortality in the general population. Therefore, we clearly need new biomarkers.
Excellent. Thank you, Giuseppe. And Cristina, I'll turn to you. And of course, obviously, conducting systematic reviews, really good systematic reviews, can be challenging. So I wanted to ask you about your methodology for this manuscript. And if you can specifically address your search strategy, your eligibility criteria, and ultimately the data extraction.
Yes, so we conducted a comprehensive systematic review following the PRISMA 2020 guidelines. Our literature research was performed on April 2024, so we didn't set any restrictions or publication start date. So essentially, every study available up to the search date was considered. And we used a simple but very targeted set of keywords. And for each included study, we collected information on the ctDNA detection methods, the specific genes or markers analyzed. We also used the QUADAS2 tool to systematically assess risk of bias across 4 key domains. And for our eligibility criteria, we focus specifically on studies assessing the diagnostic accuracy of ctDNA for distinguishing ovarian cancer from either healthy control or patient with benign ovarian histology. And to be included, studies had to use either plasma or serum sample for ctDNA analysis. They needed to include a control group, and they had to report diagnostic performance metrics such as sensitivity, specificity, or IUC. And we also consider a study that includes both epithelial and non-epithelial ovarian cancer, as long as the data for ovarian cancer were clearly reported.
Excellent. So, Giuseppe, I'll turn to you for the actual results of the study. I understand it was a total of 172 studies, 48 full-text articles assessed for eligibility, and then ultimately 19 observational studies were included in the review. What were the results you found? What were the things that you really would like to highlight for our audience?
Thank you for the nice question, Pedro. Okay, one of the key findings of our review was that the landscape of ctDNA research in ovarian cancer is extremely heterogeneous. Most of the available studies focus on epigenetic alterations, especially DNA methylation patterns as potential diagnostic biomarker. Only a smaller proportion explored other approaches such as a copy number variation analysis, often using whole exome sequencing or broader genomic profiling techniques. RASS-F1A was the most studied gene, encoding a tumor suppressor protein often inactivated in cancers. 5 studies examined the methylation changes, mostly with the other genes, making comparison very difficult. So instead of a single biomarker, a varied landscape emerged. Different detection methods, gene targets, and inconsistent terminology, such as, for example, as we told before, using a cell-free DNA for tumor-derived DNA, which is essentially ctDNA. So this variability prevented conducting a meta-analysis.
Great. So we want to get into now some of the more specific questions, and I'll go to Cristina. As this manuscript highlights, CA-125 misses up to 50% of early stage cases. We don't really have an effective screening tool. So the question is, why is early detection so challenging, and where does ctDNA potentially fit into solving this gap?
Yeah, thank you, Prof, for the question. So one important thing to keep in mind is that early detection and screening are not the same thing. Early detection usually means identify cancer as early as possible in women who already have symptoms or a clinical finding. For example, a patient with an adnexal mass and no other lesions, and we are trying to decide whether we should refer this patient to surgery instead of monitoring the mass conservatively. While when we talk about screening, the first thing we need to acknowledge is that ovarian cancer has a low prevalence in the general population. And it has been calculated that an acceptable screening method for detecting early stage ovarian cancer would need a sensitivity above 75% and a specificity of at least 99.6% just to reach a positive predictive value of 10%. In other words, unless a test is extremely specific, we end up with far too many false positives, and that makes it unsuitable for population screening. In the study we reviewed, some approaches came close to these performance targets, and one study even reported 10% specificity, but the sample size was too small to draw firm conclusions, and all of these tests still require external clinical validation. So this is a rapidly evolving field, and the accuracy is improving, but we need much larger study before any of these methods can be implemented in real-world screening. Maybe looking into the future, it's possible that a multimodal ctDNA approach combining different features like fragmentomics, methylation status could eventually achieve the necessary accuracy to be useful as a screening tool. But right now, we are not there yet for ovarian cancer.
Yeah, so exciting times. Giuseppe, I want to turn to you and talk about the technique itself. Next question is, these studies use techniques that like methylation-specific PCR, next-generation sequencing, whole genome sequencing. What do you think is the best approach, or the one that seems most promising for ultimate clinical adoption?
Okay, thank you, Pedro, and I will thank all the authors for the hard work to collect articles and examine all the articles and to reach these results. This review covers a broad range of technique, MSP, MSP, WGS, and the various NGS approaches. And it's important to note that due to limited number and the diversity of the included study, no single method clearly outperforms the others in every situation. When considering real-world diagnostic pathways, for instance, evaluating a patient with a suspicious adnexal mass, the techniques most likely to be used in clinical practice are the more targeted ones. Methods like MSP or QMSP, especially when used on well-defined methylation panels, are relatively cost-effective, easier to standardize, and compatible with the routine laboratory workflow. Similarly, targeted NGS panel provide a good balance. They can detect multiple biomarkers, including mutation and methylation changes, while still being more practical than broader sequencing methods. On the other hand, whole genome sequencing and even broader NGS approaches remain extremely valuable, mainly in research. They enable us to identify new biomarkers and gain a deeper understanding of tumor biology, but for now, they are less practical for routine diagnostic use because of higher cost, longer turnaround times, and more complex data analysis.
So with all of these different techniques and of course, obviously diagnostic accuracy being important, Cristina, I wanted to ask you, one of the most striking findings, as you mentioned previously, is the wide range of diagnostic accuracy across studies. You mentioned sensitivity ranging anywhere from 40% to 95%, specificity from 56% to 100%. Why do you think there's such a broad variability?
Yeah, thanks for this question. There are many factors that could explain this variability. First, different studies often examine different targets. And even when the methylation status of the same gene is analyzed, you may focus on distinct regions of its gene promoter. The selection of methylation sites in the promoter regions has an influence on the detection results, and this could lead to different levels of diagnostic performance. And second, methodological differences play a major role. Various analytical techniques, different thresholds for classifying samples as methylated or unmethylated, and differences in sample quality can all affect the reported accuracy. And also, study populations are not always comparable. For example, it has been shown that in patients with a higher tumor burden, you have a much better chance of actually identifying and quantifying circulating tumor DNA. So a study population that includes both early and advanced stage might lead to different results compared to another study population that includes only patients with early stage disease, even with the same target and with the same methodology.
Interesting. Now, Giuseppe, you mentioned the review notes that 14 out of 19 studies focused on promoter methylation, and some panels performed really well. So what makes methylation such a strong early detection signal?
Okay, thank you, Pedro. DNA methylation is a key epigenetic process that leads to the loss of function of tumor suppressor genes and promotes the initiation and progression of tumors. It has been noted that methylation changes frequently occur very early in the cancer development process, sometimes even before any visible morphological changes are evident. This indicates that these epigenetic modifications can be detected at an early stage when the tumor is still small or even premalignant. The second, promoter methylation is highly specific. When a tumor suppressor gene becomes abnormally methylated, the pattern is usually different from that of normal tissue. Third, methylated DNA is chemically stable. Unlike RNA or many protein biomarkers, methylated DNA fragments remain in biological samples, so this stability significantly improves detection. And finally, methylation tends to occur across multiple genes at the same time, so testing for methylation in several genes may improve the sensitivity of ovarian cancer detection. And some studies mentioned in the review used this approach by combining several promoter regions, which resulted in a notably strong diagnostic performance.
Excellent. So we'll turn over now to questions from the fellows in our journal. First question comes from Matteo Lovero at Policlinico Gemelli, and he's asking, what are the key biological and technical limitations that currently impair the reliable detection of ctDNA in early stage ovarian cancer?
Well, as as we were saying before, in several solid tumors, some studies have shown that the larger the tumor volume seen on imaging, the higher the likelihood of detecting ctDNA. This becomes particularly relevant in the early detection setting, where you expect that the tumor burden is low and the tumor shed extremely low amounts of DNA. So to detect ctDNA at this very low concentration, we would need an assay with extremely high analytical sensitivity. Then we have technical limitations that can also be method dependent. For example, looking more specifically at methylation-based assay, traditional bisulfite treatment can damage the already short fragmented ctDNA during conversion, and this loss can reduce the accuracy of the assay. Also, for these reasons, some studies found that the methylation rate in cell-free DNA was less than that of the tissue. And there are also other concerns about false positives, which could be explained by mutations that have nothing to do with the tumor, such as clonal hematopoiesis or germline mutations that are passed down through families. To give an idea of how this field is rapidly evolving, only a few months ago, a new paper published on Nature described a way to how to deal with clonal hematopoiesis, which is the presence of acquired mutation in hematopoietic stem cell, which can develop into different types of blood cell. In this study, they use a machine learning model that allows to predict clonal hematopoiesis without matching the ctDNA with the DNA of the white blood cells. That could be a very cost prohibitive and time-consuming procedure. So I think we are trying to understand how to deal with all these issues, especially when you have those plasma-only samples.
Excellent. Thank you, Cristina, for pointing out that study published in the journal Nature. Now, I'll turn to Giuseppe. This question comes from Joanny Nouveau in St. John's, Newfoundland. And she's asking, your review presents ctDNA as a promising diagnostic tool, but most included studies sample blood perioperatively in known cancer cases rather than at the point of initial presentation. Do you think the current accuracy is overestimated? And what would be the ideal study design to truly evaluate ctDNA's role in early detection in the real world adnexal mass workup?
Yes, this is a very important point. Most of the study we review collected blood samples around the time of surgery from patients with a confirmed diagnosis of ovarian cancer. In many cases, the samples had been stored years earlier, leading to significant variability in the timing of the blood draw. This suggests that the accuracy observed in this study is probably overestimated because we are testing ctDNA in a context where the tumor burden is known and often quite high. What we need now are prospective studies specifically designed to reflect the real-world clinical scenarios. So the ideal study would enroll patients at the very first presentation with an adnexal mass before we know whether it's benign or malignant. Blood will need to be collected at the initial visit with the standardized timing, standardized processing, and standardized assays.
Fantastic and great idea for those who might be interested in future studies. So, Cristina, I'm going to turn to you. Another question from Italy. This time, Tommaso Meschini from the University of Insubria. And he's asking, many of the alterations assessed in tumor-independent approaches are cancer-associated, but not organ-specific. As a result, a ctDNA test may turn positive not only in ovarian cancer, but also in patients with other solid tumors. How do you evaluate this risk of cross-detection, and how might it limit the clinical application of ctDNA as a diagnostic tool for ovarian cancer?
Yes, there is definitely a risk of cross-detection. ctDNA tests developed for ovarian cancer could also detect other solid tumors. However, in the studies we reviewed, there really wasn't enough data to really quantify how often this happens. We can only infer this indirectly from the specificity reported for each DNA assay. At this stage, some hypermethylated genes do provide a degree of tissue specificity. For example, BRCA1 promoter hypermethylation is seen more frequently in breast and ovarian cancers. And it's very likely that additional methylation patterns will be identified as the fields evolve. I would say that the more we understand the relationship between specific mutation or epigenetic changes and the tissue they originated from, the more useful ctDNA will become.
Very well. So next question comes from Marcia Pervin, University Hospital, Münster, Germany. She's asking about patient characteristics, and she says, in reviewing the literature, could any patient characteristic be linked to certain ctDNA findings, or did any particular factor stand out to you that would be interested in future research?
Yes, interesting questions. Several factors have been linked to ctDNA detectability and dynamics in the literature. One of the strongest and most consistent is tumor burden. Patients with a larger tumor, metastatic site, or greater overall disease volume are much more likely to have detectable ctDNA. Another factor is tumor biology itself. High-grade tumors, those with higher proliferation rates or more genomic instability, tend to shed more DNA into the bloodstream. We also observed differences based on tumor location and histology. For instance, in some cancers, liver metastases are more strongly linked to detectable ctDNA than lung or peritoneal disease, likely because of how DNA is cleared from the bloodstream. Patient-specific characteristics may also influence outcomes. Some studies have shown a positive correlation between age and increased methylation in the promoter regions of the analyzed genes. This may be related to an aging process that occurs independently of the subject pathological oval status and thus warrants to further investigation to understand its significance. Additionally, baseline inflammatory markers, renal and hepatic function, and even BMI have been suggested to affect circulating cell-free DNA levels, which could, in theory, impact ctDNA assays.
Excellent. Cristina, this next question comes from Paulo Matteo at Houston Methodist Hospital. And she's asking, did you observe any differences in ctDNA sensitivity or detectability between HRD and HRP tumors in your review, considering their differences in genomic instability and DNA repair capacity?
Yeah, so in our review, we included plasma-based studies exploring genomic instability markers. However, no study compares ctDNA sensitivity between HRD and HR proficient in this setting. There was a study on peritoneal fluid that we found when we screened the literature. We excluded it because our review only included studies that use plasma and serum samples. However, in that study, peritoneal fluid was shown to contain a very high amount of tumor DNA and could reliably detect TP53 mutation, BRCA1 and 2 alterations, and genomic instability with high sensitivity and also strong concordance compared to tumor tissue. But it's a different sample type and therefore not applicable to our review criteria.
So as a follow-up question, also from Paula Mateo, she's asking, multi-gene panels seem to be more powerful diagnostic tools than single-gene panels. Do the added costs associated with multi-gene panel platforms impact their feasibility in routine clinical practice today?
Yeah, this is a very interesting topic. However, in our systematic review, the available evidence did not allow us to really perform any cost-effectiveness analysis for multi-gene ctDNA panels. And in general, data on cost effectiveness for liquid biopsy are still limited.
Very well. So, Giuseppe, this question comes from Masha Pervin again. She's asking, in the studies you reviewed, did you find any case of ovarian cancer where there was no alterations in the ctDNA detected?
Oh, yes, we found cases with ovarian cancer present, but no tumor-related changes appeared in the cell-free DNA. In other words, they were false negatives. However, this is not surprising because ctDNA shedding can be very low in some patients, especially with early-stage disease. And technical factors also influence this, such as low input DNA, assay sensitivity, and the specific markers tested.
So, Giuseppe, I'll stay with you for this next question, also from Italy. Carlotta Sabini from Ospedale San Raffaele in Milano, and she's asking, the article highlights the wide methodological heterogeneity with ctDNA being evaluated through multiple techniques, as you mentioned before, that yielded highly reliable sensitivity rates. How can clinicians and researchers generate robust and clinically reliable evidence in such context?
Thank you for the question. So, to produce evidence that is genuinely strong and clinically significant, we need two things. First, prospective trials specifically designed to evaluate ctDNA in well-defined clinical settings with blood drawn and at standardized time points and processed in a consistent manner. And second, we need methodological standardization from pre-analytical handling to sequencing approaches and data interpretation so that results can be compared across studies and centers. Retrospective and real-world data have been extremely valuable for demonstrating potential, but now we need to be supported by prospective studies and standardized methodologies if we want ctDNA to become a reliable clinical tool.
Excellent. So, Cristina, this next question comes from Saniru Marin in Mexico, and he's interested about future studies. His question is, it feels like ctDNA for ovarian cancer is almost there, but many different panels, platforms, and cutoffs, but no single clear standard is currently there. If you could design the next big study or international effort, what would you personally prioritize and why?
Well, thank you for this question. I think that it depends on what are the outcomes you want to analyze. For monitoring the disease, we really need randomized controlled trials that can also incorporate this marker in treatment decisions in order to assess if ctDNA-guided therapy can be beneficial for the survival. We know that the marker is prognostic, but we still don't know what to do if a ctDNA is positive. Should we escalate treatment, de-escalate, switch therapies, add another drug? We simply don't know. And for early detection, especially the differential diagnosis between benign and malignant adnexal masses, I would prioritize these. I would prioritize integrating ctDNA, particularly methylation-based assay, into the tools we already use, like ultrasound-based risk prediction models. And finally, for screening, what we need is much more. Large population-based randomized trials, these are incredibly resource-intensive, but without them, we cannot assess whether ctDNA-based screening actually reduce mortality in ovarian cancer patients.
Yeah. And Cristina, this question comes from Joanne Nouveau, Memorial University of Newfoundland in St. John, Newfoundland. She's asking, the authors argue that ctDNA can outperform CA-125 in early stage ovarian cancer. But we do know that CA-125 is not a good diagnostic test, and you don't compare it to current multimodal imaging algorithms like IOTA or adnex. In your opinion, will ctDNA realistically replace or will it complement imaging? And if so, at what exact point in the diagnostic pathway do you see its future value?
Yeah, thank you for this question. In real clinical practice, we rely on more on risk predictive models, such as adnex, to discriminate between benign and malignant adnexal masses. There is actually a newly published study from the IOTA group that look at adding cell-free DNA to the adnex model. And what they found is that adding cell-free DNA biomarkers to the adnex ultrasound models offer only marginal diagnostic gains. And the net benefit analysis confirmed that this improvement is clinically limited because you need hundreds of additional patients tested to gain just one extra true positive result. But this doesn't rule out the possibility that more sensitive ctDNA assay could complement imaging in the future. So I think that when ctDNA testing could be useful is during the assessment of the risk of malignancy. This could improve differential diagnosis, complementing imaging, and helping us reducing the burden of unnecessary surgeries.
So, Cristina, the last question is a question that we always pose to artificial intelligence, our AI platform. And that's when AI reads your paper and formulates a question. This is the question that came from AI about this article. The review highlights numerous multi-gene methylation panels reporting greater than 90% sensitivity, specificity, yet none have been externally validated or replicated across populations. Why do the authors not address the high risk that these results represent overfitting, publication bias, or assay-specific artifact rather than true biological signal?
Yeah, so we agree with AI that the very high sensitivity and specificity reported by some multi-gene methylation panels must be interpreted with caution. As we point out in the discussion of the manuscript and in the QUADAS 2 assessment, these findings are limited by the lack of external validation and heterogeneity of methods. And there is the possibility, of course, of publication bias. So yes, these risks are real, and that's exactly why we need prospective trials, external validation, and methodological standardization before ctDNA methylation panels can move into the clinical practice.
Excellent. Thank you. You handled that question from AI quite well. AI could pose some really challenging questions, I see. So, Cristina, Giuseppe, thank you so much. And again, congratulations. Really very important work. I think this will help all gynecologic oncologists. And of course, obviously, more and more patients are coming to us with questions about the utility of ctDNA in all kinds of settings. We often are seeing now patients getting ctDNA during surveillance visits. Certainly a very interesting opportunity for further research. And thank you actually also for highlighting some additional potential research opportunities. So I think many members of the audience will likely take you up on some of those ideas. But I do want to thank you and also congratulate to all of the other co-authors. I know that this must have been a daunting task.
Yeah. Yes.
And again, we look forward to additional work from both of you. And good luck in Heidelberg as well, Cristina.
Thank you very much. Thank you again for your invitation, and would like to wish a bright future for the International Journal of Gynecological Cancer.
Thank you, Pedro. Thank you for your collaboration.
Thank you.